over the country or all over the state to get treatment. We're stuck in this kind of thing right now, but it's evolving very rapidly. And so, if places like David and others have a registry that a community hospital could participate in and has the necessary infrastructure to be able to adhere to all of the protocol, whatever the ingredients are, composition, then that's where it should be. I really believe that everyone if they're going to get treated, they have that information. It's our obligation to get that in a way that it can be studied, and we can learn from that, and that those patients' experience will not be in vain in terms of the research of this. So that means that I think you can't, and right now the thing that's missing is the post-procedure. And the reason it's missing is obvious, because you may have money to come get it done somewhere, that the light is turned on and people are treating, but you may not have the money nor the desire to come all the way 4,000 miles back to get follow-up. And that's where the whole thing kind of falls apart.
I think this audience would be interested in your fellow or your student's result with the mouse, ligating the internal jugular mouse.
Yeah,
one more question I wanted to is, no one seems to have treated the vertebrals, mice.
No one seems to have treated what?
The vertebral veins.
No. Well, in mice, they have two frontal veins, which are basically facial veins. And we've been looking at this model. As many of you that are really into MS know, that there's an animal model, but it's not really, as unfortunately like most animal models, it's not really a human model. Basically, you take a gamish of ground up spinal cord and brain from some other species, you mix it with some oily substance, some TB bacilli, and some Bordetella pertussis or whooping cough toxin, and inject it intraperitoneal. And what you get is this whopping inflammatory response. And obviously, and that's good because you get an accelerated disease process, but obviously in humans, it's a much more chronic, progressive thing. So what we've done is taken mice and ligated, and we're going to move now up to marmosets because that's the next level of the species. And marmosets, you can actually partially occlude veins and keep them open, but not without totally ligating them. And in these mice, at any rate, we've got a recipe that we think is right where we want, and we're starting to see not only clinical performance differences between mice that are ligated and mice that aren't ligated, but now there's a way to tomographically in a little mouse brain make these wafer-thin micron sections through the whole brain. And we're learning a whole lot, and I think it's going to be very interesting as we move up to a larger model to really see, but we think that we're seeing an accentuation certainly of venous ligation, I'll leave it there. I mean, of the venous ligation on the disease process. And the other thing you should know is vis-a-vis, we've been talking about sex in these mice, there's a real sex difference too. And if anyone wants to talk about it, I'm on board with that. We can talk about it later. Yeah. Well, again, in the vertebral, when you see this, the problem is again, this, and Jack can correct me if I'm wrong, EAE is intense, it affects the spinal cord very badly. But when we're tying off the jugular veins, we're not affecting the spinal cord. So we're really, it's a different, we have not yet really done anything with vertebrals. Yes?
Are you measuring or documenting pullback venous, pullback pressure?
Yes.
In patients?
Yes, every case.
Pressure gradient before and after?
Yeah, there are pressure gradients, but these aren't whopping pressure gradients. Think if there's an orifice there, basically when you're supine, you're basically like a cookie sheet filled with water. Stuff is sloshing all over the place, It's not like benign intracranial hypertension or pseudotumor where these pressures really, really are high. We average somewhere about between 4 to 5 to 6 millimeter of mercury gradient. But after treatment, if it's effective, usually we're down. When you get down to these gradients, there's a lot of variation. But certainly we expect to see a decrease in that gradient post-treatment. So we rely on that to know if we've adequately treated. It's not. It's sort of a sledgehammer. It's not the most, delicate way to look at this, but that we do it in all patients.
In the absence of a gradient, but where you see a stenosis, would you still do a biopsy?
Yeah, we would, but that's a situation we don't see very often. We expect, I mean, if we're convinced there's a stenosis by multiple modalities, if there's no gradient, we will have a low threshold for treatment.
Well, thank you, Dr. Dake.